We're good to go, sir.
Okay, thank you. Good evening, friends. Welcome to Tuesday regular our classes from the Department of Critical Care Medicine, Yashoda Hospitals. We bring forth these interesting topics regularly to discuss these topics with our distinguished expert panelist. I am Dr. Kaladhar, Head of the Department of Critical Care at Yashoda Hospitals, Malakpet. So today's topic of discussion is beat the heat. So we had seen recently across different social media that most of the cities in India, the temperature crossed even up to more than 52 and all. So we had seen lots of heat waves that caused heat strokes in some patients, and we had seen deaths also across the newspapers and all. So it becomes important to discuss this topic, and it's very important as the temperatures rise, how to understand, how to recognize, prevent, and respond to heat stroke in any patient. It becomes crucial, the knowledge of this topic especially. So for this topic, it's my pleasure to invite our distinguished expert panelist, Dr. Srinivas Samavedam, sir. He is the senior consultant head of the department, Ramdev Rao Hospital, and sir is president-elect Indian Society of Critical Care Medicine. I can say his contributions to the field of critical care medicine is both impactful, and I think it's very influential across different students. I can say sir's advanced knowledge and sharing with students inspired and continues to inspire countless students and colleagues. It's my pleasure to call you, sir. Thank you coming onto the board. Welcome, sir.
Thank you. Thank you.
Yeah. To discuss this topic, I invite my friend and colleague, Dr. Ravisankar. He is a senior consultant in Yashoda Hospitals, Hitec City. I think let's get started, Ravi. You can share the PPT and just start. Thank you.
Yeah. Thank you, sir. It's indeed a privilege for me to talk in front of Samavedam sir, who is a stalwart in the field of critical care medicine. Thank you, sir. So to begin with, I'll be talking on beat the heat with some insights on heat stroke and how do we approach hyperthermia in the ICU. So before we begin, we go into the core topic. We will have few case scenarios. We'll start with the first case. This is a 36-year-old male who is a software engineer by profession with no comorbidities actually. He is actually a regular marathon runner, and of late he has modified his diet and he was on some keto diet, and he was running for a marathon where he had sudden collapse while running the marathon, which he used to do regularly. So immediately he was recognized by a bystander who started CPR immediately, and as there was a nearby ambulance which was accompanying the marathon runners, retrieved into the ambulance, and by the emergency technician, ACLS was initiated, and within 5 minutes circulation was restored actually. So he was shifted by ambulance to our hospital. So on arrival to the hospital, he was already on ventilator with GCS of E1 VT-M1 with pupils of 2.5 mm, and he was quite tachycardic, tachypneic, and with a blood pressure on the lower side, and he was maintaining SATs of 100% on FAO of 100. He has very high temperature, which is around 107 degrees Fahrenheit, and he was diaphoretic with a lot of sweat, and systemic examination was unremarkable. ABG was done. ABG was suggestive of metabolic acidosis with lactatemia. Subsequently, all relevant investigations were sent, and he was shifted to ICU for further management. On arrival to the ICU, patient was very restless, irritable, and he was very agitated, trying to jump out of the bed, because of which he was started on sedation, and in view of metabolic acidosis with increased lactate with marathon running, we started him on IV hydration based on echo-guided IVC assessment, and ABG was gradually getting better with decreasing lactates. As a part of the evaluation, we also have sent CPK. CPK levels were elevated around 6,000. And because he has a history of sudden collapse, we did a CT brain, which was normal, and 2D echo was also ECG and 2D echo were normal. Although drop was elevated because it might be because of post-cardiac arrest. He was ventilated overnight. Gradually, he returned to his baseline and he was extubated next day. So I would like to, ask the students, what would you put a differential diagnosis in this patient? You can post your answers in the chat box. So this is the first case. And we'll go to the case number 2. This is another patient which we had recently. This is a 65-year-old male who is a known diabetic, hypertensive, history of coronary artery disease with history of recurrent CVA, multiple infarcts, quadriparetic, and he was limited to bed with very minimal activity. However, family also does give history of aggressive behavior at home, for which he was on some medication, the details of which were not available to us. So to begin with the complaints, he had a history of fever for last 3 days, which was around high-grade fever, and for which he was evaluated by a physician who visited home, and they were treating him in lines of UTI as he has a prior history of UTI. So there, at the local native village, the labs were showing progressively worsening creatinine, and in view of decreasing urine output, patient was shifted to our hospital. On arrival to our hospital, patient was quite tachycardic and tachypneic with a fever of 107, and he was in shock. In view of his suboptimal GCS and shock, patient was intubated in the emergency. Again, an ABG was done, which was suggestive of severe metabolic acidosis with lactatemia. Patient was shifted to ICU. Creatinine was around 4. His baseline creatinine is around 0.9. And CEU, surprisingly, was normal with no pus cells. Leukocytosis was negative. And CPK was asked for this patient also, and CPK was around 26,000. So patient was initially started on hydration. However, despite hydration, there was no urine output, and in view of worsening acidosis, patient was started on CRRT in view of AKI with shock. However, during the CRRT, what we observed was there were significant hemodynamic fluctuations with rapid changes in his heart rate and heart rate dependent change in his blood pressure. We did ask for a cardiac evaluation because with his background of coronary artery disease, cardiac evaluation was done, 2D echo and ECG were normal. All cultures were sent, and pan cultures were reported as negative, and patient's shock and acidosis got better, and by next day, patient was extubated. So I would also like to ask the student what differentials could be possible in this patient. So with this background, we'll start with, what exactly is hyperthermia. Hyperthermia is defined whenever there is a core body temperature going up more than 41 degrees centigrade. So it is usually above the thermoregulatory set point. What I mean by thermoregulatory set point is human body has, a mechanism to balance the heat production as well as heat dissipation. The heat production is basically because of the metabolic processes as well as the temperature in the environment. So this will be balanced by the heat dissipation mechanisms, which the control will be at the level of the hypothalamus. Usually, the hyperthermia is different from the fever. Fever usually happens because of the inflammatory pathways and the release of the cytokines and interleukins. And usually the fever usually does respond to the pharmacological therapies, whereas hyperthermia usually doesn't respond to the pharmacological therapies. If you look at the common causes of hyperthermia, there are few common causes which we generally come across. The first one is the heat stroke, which is usually seasonal, depending on the environment where we are living in. And there are other differential diagnoses which we can think of, depending on the context of the patient, like malignant hyperthermia, neuroleptic malignant syndrome, and serotonin syndrome. Rarely there are few endocrine disorders which does also present with hyperthermia, like thyrotoxicosis, adrenal crisis, and pheochromocytoma. And there are other syndromes which can also present with very high fever whenever there is a neurological patient presenting with high fever, or patients with an anticholinergic overdose does also present with hyperthermia. So this is what we were talking about, the thermoregulation. The thermoregulation usually is in the preoptic nucleus of the hypothalamus, which is sensing the inputs from the thermoreceptors, which are at different locations. There are peripheral thermoreceptors as well as the central thermoreceptors. Peripheral thermoreceptors are usually at the skin level. Central thermoreceptors are usually at the spinal level, visceral level, and all the inputs will reach the hypothalamus, based on which it will control the afferent fibers of the sympathetic nervous system, which will help us in dissipating the body heat and bringing down the temperature. So usually the temperature is regulated between 37 degrees centigrade plus or minus 1, or if you look at in the Fahrenheit, it is around 98.6 Fahrenheit plus or minus 1.8 degree Fahrenheit. If you look at human body is uniquely, unique in the sense it can tolerate extreme cold, but however, it is very sensitive when it comes to high temperatures. It can only tolerate changes up to 4.5 degrees centigrade or 9 degree Fahrenheit. There are four principal mechanisms. If you look at how the body is able to dissipate the heat, that is evaporation, which is the principal mechanism. And there are other mechanisms like conduction, convection, and radiation. Evaporation is nothing but the body tries to dissipate the heat depending on the environmental temperature. It will try to dissipate the heat through sweat mechanisms. Again, it depends on the relative environmental temperature as well as the relative humidity of the environment in which we are in. This is the principal mechanism which will help us in dissipating heat. There are other minor contributions either through conduction, convection, or radiation, which are less contributory when you are talking about heat balance. And we also have to understand there are two important things, that is heat stress and strain. That is how your body is able to take upon the heat stress depending on or cope up with the environmental temperature. And what are the consequences of the temperature on your body is nothing but heat strain. So if you look at the exertional heat illness or the heat related injury, there are few classifications which are given actually. There is no unified classification, but however, we try to look at the different clinical contexts in which we see this exertional heat illness. The first and the most common is the heat cramps. That is, whenever you are doing an exercise, you generally experience cramps, and these cramps are exacerbated when you are doing it in a hyperthermic environment or when the environmental temperature is very high. So heat has nothing to do with these cramps. However, heat can only precipitate or worsen the symptoms. That's why it is also called exertion-associated muscle cramps. The second clinical syndrome which we come across is the heat syncope, that is exertion-associated collapse. That is, whenever you are doing a physical activity or physical exertion in a heat or high temperature, usually you can experience this lightheadedness or dizziness, and you can have a syncopal attack. So that is why it is also called as exertion-associated collapse. This is very commonly seen in soldiers, military environment, when they are doing high-intensity training in the high temperatures. This is also commonly seen in the construction workers. But the point of interest for us is the heat exhaustion, heat injury, and heat stroke. So heat exhaustion is nothing but whenever you are doing a high physical activity in a high environmental temperature, there may be an inadequate cardiac output because you're doing a physical activity. The body is trying to improve the blood supply to the peripheries. And when you're doing such a high activity in a high temperature, the principal heat dissipating mechanism is through the loss of sweat. Again, your circulation is redirected from the splanchnic to the peripheries, which will lead to inadequate cardiac output. And then the patient can either experience inability to complete the activity or has to stop doing that activity because of the exhaustion. That is nothing but heat exhaustion. Heat injury is when you encounter the same syndrome with an end organ injury. This end organ injury can vary from a very mild injury to lethal injuries. And usually the common thing what we see is usually acute kidney injury in the form of rhabdomyolysis, or when it is so extreme, you can end up seeing disseminated intravascular coagulation too. However, what differentiates these two syndromes from heat stroke is that you don't see usually neurological manifestations. When you see a neurological manifestations along with whatever we are seeing, that becomes a heat stroke. Again, heat stroke can happen because of exertional or non-exertional, which we will look into. And if you look at, there are some factors which will usually predispose to heat tolerance among the adults. That is, there are functional factors, acquired factors, as well as congenital factors. Functional factors is when you start doing suddenly a physical activity with a lack of training, or when you intensify the exercise without acclimatization. Usually this acclimatization takes around 1 to 2 weeks. So without this, when you start doing vigorous activity, that is when you can be predisposed to these clinical syndromes. Or when you are having high BMI or a reduced skin area. Principally, this is because your dissipating mechanism is lost. And again, something similar is your congenital. Whenever there is a problem with your sweat production mechanisms, again, this can predispose to these syndromes. There are acquired factors like when you are suffering from some medical condition like fever or dehydration, or you have a sweat gland dysfunction, or you are exposed to some medications to augment your physical activity, or use of alcohol prior to such a strenuous activity, all can predispose to heat exertion. If you look at the list of drugs which can contribute to this, almost all the drugs which are routinely used can predispose to this exertional heat illness. The routinely used analgesics like NSAIDs, anticholinergics, antihistaminics, and anti-Parkinson's medicine, anti-epileptics, antispasmodics used to treat bladder, antihypertensives like ACE inhibitors, ARBs, psychotropics, or addictives like cocaine, amphetamine, alcohol, all these can predispose to exertional heat illness. So when you talk about exertional heat illness, what is most important is, as you see the patient, the most important step would be to cool the patient rapidly after you have measured the temperature. Usually the temperature will go as high as 104 degrees and above. So we should try to rapidly bring down this temperature as early as possible to 101 degrees Fahrenheit. So the principles almost remain the same. That is a airway breathing circulation. So measure the vitals, then start cooling the patient as early as possible. Try to move the patient to a shaded area. Try to remove the clothing. Because of the clothing, again the sweating mechanism will be disturbed. And try to cool the patient with different mechanisms. Like you can either put the patient in a tub with water and ice and try to either put ice water on his body or wrap him with a sheet with ice contained in it. So there are different mechanisms. Ideally, the temperature should be brought down as early as possible to 101 degrees centigrade. And again, the rapidity of the cooling is also important, because once the temperature is reached to 101 degrees centigrade, you try to shift the patient as early as possible to the nearest health care facility. So usually the cooling in ice water immersion, at least for 1 degree centigrade drop is expected for every 5 minutes, or 1 degree Fahrenheit for every 3 minutes. So the two principles when you're treating a heat attack is, even though the patient may appear normal, there may be delayed signs and symptoms, because of which you might actually miss treating the patient. And one more important factor is the duration of pyrexia. The longer the patient has high temperature, the longer is the organ injury, and the rapidity of the cooling. Once you are diagnosed or suspected that this patient might be having a heat stroke or heat exhaustion, try to bring down the temperature as early as possible to prevent the consequences. As discussed, the goal temperature is to bring as early as possible to 101 to 102 degrees Fahrenheit. Cool first and transport second if it is safe enough. Otherwise, try to transport as early as possible if you are not able to find any cooling mechanisms. The resuscitation principles remain the same: airway, breathing, circulation. And during the transport, if you are able to do a basic investigations, try to look upon blood glucose and sodium, which is very commonly seen in exertion. Hyponatremia is very common. And whenever we are measuring the temperature, what is very important is you cannot use the surface temperature measurements. You ideally have to choose a rectal temperature probe only to measure the temperatures. Then coming to the complications can vary depending on patient to patient. Usually what we see is acute kidney injury, acute liver failure in the form of transaminitis, rhabdomyolysis, and seizures are the very common complications what we see when you are encountering a patient with exertional heat illness. So this is not the only spectrum what we see. If I give you a clinical scenario, like if you find a patient who is, found unconscious in a home with high temperature, the differential diagnosis is quite exhaustive. Why the patient has hyperthermia? It could be simple heat stroke. It could be, something more than that. So whenever you encounter a patient with hyperthermia in the ICU, you also should have a differential diagnosis for the patient, because not always that it is only heat stroke. You should also think about other causes of hyperthermia in the ICU. One among them is the neuroleptic malignant syndrome, which we commonly come across. Basically, it is nothing but a life-threatening neurological emergency because of the use of antipsychotic agents or the neuroleptic agents, and it is characterized by a classical tetrad of fever, rigidity, mental status changes, and dysautonomia. Although conventionally it has been described that neuroleptic malignant syndrome is very common with first generation antipsychotics, it is also common with second generation antipsychotics, or even it is very commonly associated with the common antiemetics which you use like metoclopramide 2. So, neuroleptic malignant syndrome is a clinical diagnosis based on suspicion depending on the context of the patient. A patient who has been using these medications, when presents with this classical tetrad, you should have a high clinical suspicion for this neuroleptic malignant syndrome. If you look at its pathogenesis, basically it is because of dopamine receptor blockade, and it is also because of the central dopamine receptor blockade in the hypothalamus, which can cause hyperthermia and other signs of dysautonomia. There is another similar entity which is described in Parkinson's patients, which is called neuroleptic malignant-like syndrome or Parkinson hyperpyrexia syndrome or acute akinesia or malignant syndrome in Parkinson's disease. Basically, this is nothing but whenever a patient is on a dopamine agonist, either you have replaced the drug or decreased the dose of the dopamine agonist, you see a feature similar to neuroleptic malignant syndrome in this Parkinson's patient, which is similar to neuroleptic malignant syndrome. As described, it is a classical tetrad, and usually CPK elevations are seen in these patients. If you look at the prodrome, the patients will have begin with have mental status changes. That is, patients will start have agitating behavior or a delirious behavior, and subsequently the patient will start with fever, rigidity, and then once the patient lands up in your ICU, usually you see organ failure in the form of rhabdomyolysis and AKI. And in the hospital, autonomic dysfunction is commonly witnessed in these patients. So if you look at the diagnostic criteria, there is some scoring system which was given by the expert panel depending on the priority of the scoring. Like the highest scoring will be given to a patient who has an exposure to dopamine antagonist or a patient who has dopamine agonist withdrawal within the past 72 hours. Patient present with a classical tetrad of hyperthermia, rigidity, mental status alteration, and autonomic dysautonomia. So based on this score, there is no cutoff point, but a higher score will indicate more likely probability of your neuroleptic malignant syndrome. Treatment, because you know the cause, try to discontinue dopamine antagonist therapy or resume the patient on dopamine agonist in case of withdrawal. And there are other potential contributory causes like patients who are already on some other forms of therapy like lithium, or patients on anticholinergic therapy, which can again affect your heat dissipation mechanism, can worsen this neuroleptic malignant syndrome. So once you diagnose this syndrome, basically cooling again and maintain euvolemia. When the patient has rhabdomyolysis, try to resuscitate the patient with volume fluids, and urine alkalization may help in this patient. And to control the agitation, use of benzodiazepines is recommended. Do not restart these patients on conventional first generation or even second generation antipsychotics because it can worsen the clinical condition. Or do not use any anticholinergics also in these patients, which can worsen it. So for moderate to severe neuroleptic malignant syndrome, benzodiazepines are preferred to control the agitation in muscle rigidity. If you are not able to control it, probably securing the airway and ventilating the patient might help with use of dantrolene. Dantrolene is the recommended drug for treating these patients. However, it is not available in India, because of which we tend to prefer to use other alternative agents like bromocriptine, or amantadine can also be used for control of moderate to severe symptoms. The second other common condition which we come across in the ICUs is malignant hyperthermia. Malignant hyperthermia is an autosomal dominant disorder. Basically, it is an hypermetabolic crisis seen in susceptible individuals exposed to particular triggers. Basically, it is a problem with the skeletal muscle receptor abnormality, where there can be abnormalities in the ryanodine receptor, which leads to intracellular calcium accumulation, which leads to repetitive muscle contraction and muscle rigidity. So again, these patients also present with features of hypermetabolism, either hypercarbia, rigidity, and hyperthermia. However, if you look at the clinical context of malignant hyperthermia, these patients, usually we see these patients in the intra-op settings. That is, whenever a patient is exposed to volatile anesthetics or succinyl choline, the patients may either develop hyperthermia, masseter rigidity, or unexplained increase in the end tidal carbon dioxide despite your mechanical ventilation. That is when your suspicion should start. And because it can worsen rapidly as and when you start suspicion, treatment with early treatment with dantrolene is recommended. And even if you look at the guidelines, the ASA guidelines also do recommend that any procedure which is lasting more than 30 minutes of anesthesia, core temperature monitoring is very important, because this helps us in picking up malignant hyperthermia early. And although we do say that it can happen to patients who are exposed to volatile anesthetics and succinyl choline, there are many case reports where patients have been previously exposed to these drugs without development of the malignant hyperthermia, do develop this setting on the subsequent exposure. Whenever there is a documented episode, malignant hyperthermia susceptibility testing is recommended for the family, and no further volatile anesthetics are recommended for these patients. If you look at the clinical indicators for malignant hyperthermia, there will be hypercarbia. In a patient who has been on controlled ventilation, an ETCO of more than 55 or a PSCO of more than 60 is significant. In a patient on spontaneous ventilation, ETCO to more than 60 or PSCO to more than 65. And it again presents with muscle rigidity, that is masseter is a usual muscle what we see commonly following succinyl choline administration. Arrhythmias are very common. These are secondary to the hyperkalemia, which develops during the course of the problem. And usually you see respiratory acidosis followed by metabolic acidosis. So you see a combination of both respiratory and metabolic acidosis. hyperthermia with a core temperature going more than 38 degrees centigrade. And rhabdomyolysis is one of the prognostic marker in these patients where it will be significantly elevated. Management, discontinue the inhaled anesthetics. All the inhaled anesthetics are known to be associated with malignant hyperthermia. Halothone very commonly, although isoflurane, desflurane, and sevoflurane are also associated with malignant hyperthermia. And increase the fresh gas flow to more than 10 liters per minute and use non-triggering agents for remainder of the procedure. So if possible, try to abandon the surgery. If not possible, try to complete the surgery with intravenous anesthetic. If the patient's airway is not secured, try to secure the airway. And you can either use a carbon or charcoal filters to eliminate this. And if you have an dantrolene which is available with you, dantrolene is the drug of choice for treating malignant hyperthermia, 2.5 mg per kg for a maximum dose of 10 mg. And treatment is recommended even 24 to 48 hours at an interval doses. And again, hyperkalemia is very common in these patients. Try to treat the hyperkalemia because arrhythmias are very common. And avoid calcium channel blockers. Most arrhythmias respond to correction of hyperkalemia and acidosis. And again, cooling is very important in these patients because rhabdomyolysis is very common. Insert a Foley's catheter, try to monitor the output and give good hydration along with diuretics to flush out. The third and the last common syndrome, which is commonly seen, is serotonin syndrome. Serotonin syndrome is again a potentially life-threatening condition, basically because of increased serotonergic activity in the central nervous system. Either it can develop in patients who are already using serotonin agonists, or inadvertent interaction between the drugs, or intentional self-poisoning in a patient who has been antidepressive on SSRIs. So again, it is have a triad of mental status changes, autonomic hyperactivity, and neuromuscular abnormalities. So this is the Hunter algorithm for approaching a patient with serotonin syndrome. If you have a patient who has been on serotonin antagonist, if the patient has a spontaneous clonus, then the diagnostic criteria for serotonin toxicity or serotonin syndrome is met. If the patient doesn't have a spontaneous clonus, the patient has an inducible clonus or ocular clonus along with any of the following like agitation, diaphoresis, hypertonic, and temperature more than 38 degrees. Again, it is a diagnostic criteria for serotonin syndrome. If even these features are not present, the patient has tremor and hyperreflexia. Also, a diagnosis of serotonin syndrome can be made. So usually it is basically because of overdose with a serotonin agent, except direct serotonin receptor antagonist or a combination of two serotonin agents. Usually, if you look at the drugs which can precipitate this condition, usually monoamine oxidase inhibitors are the most common drugs which can cause serotonin toxicity, followed by SNRIs, that is serotonin noradrenaline reuptake inhibitors. Comparatively, serotonin reuptake inhibitors have low incidence to cause serotonin toxicity. The Hunter criteria for diagnosis of your serotonin toxicity is the patient should have a spontaneous clonus or inducible clonus and agitation or diaphoresis, or ocular clonus and agitation or diaphoresis, tremor and hyperreflexia along with hypertonia, temperature more than 38 degrees centigrade. So if you look at neuroleptic malignant syndrome and serotonin syndrome, they look very similar. But if you look at serotonin syndrome, clonus is a cardinal manifestation of serotonin syndrome, whereas rigidity is very common manifestation of neuroleptic malignant syndrome. And once the diagnosis of serotonin syndrome has been made, discontinue the serotonergic agents. And it is very common practice to use benzodiazepines to control the agitation and neuromuscular irritability and clonus. And you have to supplement IV oxygen along with IV fluids, and a continuous cardiac monitoring is required because of the arrhythmias it can cause. And if benzodiazepines are not able to control the agitation or the patient is having an abnormal course, then use antagonists like cyproheptadine at least 12 mg orally. So usually you should avoid acetaminophen in this condition. And if you are not able to control the hyperpyrexia, even with conventional measures, probably securing the airway is very important, and treat hyperthermia with cooling to bring down the temperature. If you look at the neuroleptic malignant syndrome, it usually develops slowly over days to weeks, whereas serotonin syndrome develops very rapidly, and with treatment also it responds very rapidly. That is a good differentiating feature between serotonin syndrome and neuroleptic malignant syndrome. Thank you.
Thank you, Dr. Ravisankar, for that, I think, extensive all the round coverage of different hyperthermia syndromes and all. Yes, sir. Srinivas, sir. So basically, if we look at, as Dr. Ravi was pointing out, towards exertional heat stroke versus non-exertional, because during summer, especially if you look at a scenario where a middle-aged woman in a sealed room in the summer, presenting with a very high temperature, may pose very like broad differential diagnostic possibilities as compared to a regular athlete who go for a marathon and he develops very high temperature, because it's straightforward in that. So basically, how to differentiate, sir, especially the non-exertional or nothing but the classic heat stroke patient, when they come to you, who is a bit sick and all, how to differentiate these patients?
Thank you, Kaladhar. Excellent presentation, Ravi. It's a comprehensive review of how to look at a hyperthermic patient. Coming to the first point, how do you differentiate between exertional heat stroke and non-exertional heat stroke? There are subtle, telltale differences between the two. As has been already mentioned, exertional heat stroke usually occurs in a relatively young, relatively fit person who has been used to sudden exertion, sudden unaccustomed exercise, or more than normal exercise, or strain on the physical structure. Whereas non-exertional heat stroke usually happens in elderly, those who are confined to bed, who have a high body mass index. Other comorbidities like diabetes, those are relatively common. But what we need to understand is patients who are on anti-Parkinson's medications are at a higher risk of developing heat stroke if they are exposed to any degree of higher temperatures. The other side of the story is metabolic acidosis is usually a dominant ABG abnormality in exertional heat stroke, whereas respiratory alkalosis is a predominant hallmark of patients with non-exertional heat stroke. DIC is a prominent feature of exertional heat stroke, is very mild in non-exertional heat stroke. The rapidity of onset of altered sensorium is very fast in exertional heat stroke. It is a gradual diminution of sensorium in non-exertional heat stroke. Rhabdomyolysis is very common in exertional heat stroke. It is very mild and usually does not result in ATN in patients with non-exertional heat stroke. Usually, use of drugs of recreational use, recreational drug use is often associated with both types, but it predisposes more to the non-exertional type of heat stroke. So the peak of temperature, right, like from say a normal body temperature of 99 to 105, 106, takes about half an hour to 45 minutes in exertional heat stroke, whereas it takes about 24 to 36 hours to reach the temperature in non-exertional heat stroke. Altered sensorium, coma is a predominant feature of exertional heat stroke, whereas altered sensorium, irritable behavior, neck rigidity, um, these kind of focal signs, these are all more of in non-exertional heat stroke. So you can differentiate, and dantrolene should not be used in patients with exertional heat stroke. It should not be used in patients with exertional heat stroke.
Yes, sir.
These are some of the.
I think it is very clear, sir, after so many differentials. Like generally, it's a gradual effect on in patients who are having classical or non-exertional heat stroke. So basically, these the classical heat stroke patient, once they come to ER, So because there are broad differential, it's very difficult to rule out the infection at the initial part of the illness of these patients who come to here. So at that point of time, what do you think, sir, regarding like sepsis, whether we have to start antibiotics, send cultures, still will keep the differential of sepsis on the on your card and continue like that, or directly we can just roll in?
So, yeah, see, if it is a non-exertional heat stroke, somebody who's had a stroke has been confined to bed, is getting tube fed. There is always this risk of aspiration pneumonia, pressure sores, community-acquired UTI because of a long-standing indwelling catheter, or a nosocomial sinusitis because of a long-standing nasogastric tube. These are all possibilities. But what one must remember is that sepsis very rarely produces a temperature of more than 104 or 105. If you have a patient who's behaving abnormally, who's on anti-Parkinson's or some of the psychotropic drugs, has been confined to bed in a hot environment with an air. People think you put an air cooler, everything will be fine. But if you put an air cooler with the room closed, it is a much bigger disaster than not having the air cooler. So if you have such a situation and your temperature, as Ravi said, core temperature is more than 104, sepsis should come low down in your possibilities. Unless you have a brainstem encephalitis which has reset the cerebral thermostat, which is very, very rare in adult population. It may happen in pediatrics, but in adults it is very, very rare. So if you have a temperature of more than 104, look at a neuroleptic malignant syndrome or a non-exertional heat stroke if the ambient temperatures are high. So non-exertional heat stroke usually happens in seasons like this when the outside temperatures are high. Whereas exertional heat stroke is sporadic. It can happen anytime. It can happen even in winter. If somebody climbs Mount Everest without getting used to that kind of exercise, you can get exertional heat stroke. The body is exposed to unaccustomed energy, utilization. So the core temperature measurement is the important aspect. The second point to remember is toxic granules and band forms are never part of the heat stroke peripheral smear, although evidence of DIC may be seen in the heat stroke peripheral smear. But if you have more than 10% band forms, your temperature is less than 104, you put infection as your first possibility and heat-related disorders second and third in that order of priority. Procalcitonin, unfortunately, is not a discriminant to differentiate between infective fever and hyperthermia or temperature disordered thermoregulation related disorders.
Yes, sir. So these patients, if they come, as Dr. Ravi was pointing out towards the different cooling measures, so most of the like periphery or district centers and all, they may not be having the option of these invasive devices and all. So what generally what we follow is simple measures. Generally, how to follow that any like simple protocol like how to do it and all for the doctors who are there
So
in the.
there lot of studies have been done on using intravascular extracorporeal techniques to cool patients. The outcomes are not much better than if you use surface cooling using ice packs in the groin and axilla and around the neck. There may be certain situations where there is a myocardial stunning because of the heat stroke. There may be rhabdomyolysis. There may be an ARDS which has happened because of heat stroke. In such situations, an extracorporeal membrane oxygenation, preferably a VA ECMO with temperature regulation, can actually help you to regulate the core temperature of the patient. But the mistake we should not do, the common thing which people do is to dip a blanket or a bed sheet in water, put it on the patient, and then switch on the fan. Now that kind of convective cooling actually causes more shivering, and shivering exacerbates the hyperthermia and the hyperkalemia associated with hyperpyrexia. So that is not going to work. You want to cool the patient, put the blankets all around the patient on the bed, around the bed, and switch on the fan. But don't put it directly on the patient and then switch on the fan, because that will not work in the first place. Second, it will trigger shivering.
And the role of antipyretics, absolutely
So
known.
your
Most of the
labs actually
effect-
will have those ice packs on which you transfer your lab samples. The ice packs, those are good enough to cool patients in the remote periphery. Sorry to interrupt you. Actually.
Yes, sir. Yes, sir. Okay. Yes, sir. I think putting them in the groin, axillae, and even surface cooling, yeah, is as effective
Yeah.
as invasive device. Yes, sir. The role of antipyretics, sir. Yeah, most of the people has a knee-jerk reaction once we see the temperature, even if it is the high possibility of heat stroke. One we will start the antipyretic. What do you think? So they are not as effective or
So acetaminophen, apart from yeah, acetaminophen can be used for exertional heat stroke, but it cannot be used for the other forms of neuroleptic malignant syndrome and malignant hyperthermia. It cannot be used in those scenarios. But at the other side of the story is exertional heat stroke is more often associated with hepatic necrosis. You have elevation of transaminases in patients with exertional heat stroke. So in such patients, probably ibuprofen and naproxen are better choices as antipyretics than acetaminophen or paracetamol, whatever you want to call it.
yes, sir. So regarding hemodynamic management, sir, most of the times because of the heat exposure, they will be having lots of vasodilatation, leading to, especially as you were telling, pointing out regarding myocardial stunning. So if these patients initially anyway will try to fluid resuscitate, suppose if still looks like refractory. So what do you think, sir? The choice of vasopressor initially, how to go about it, sir? Hemodynamic management.
So, peculiarly, these patients don't respond very well to sympathetic amines like norepinephrine and epinephrine. But that's the only choice we have. Amongst them, there are some people who believe that adrenaline is a better vasopressor, um, uh, better vasopressor in heat stroke. But there's no randomized control trial. There is no comparative study which says so. But with the availability of extracorporeal membranes, of extracorporeal support, real ECMO may be a good way of supporting these patients who have myocardial stunning, as well as vasodilatory state of heat stroke, especially non-exertional heat stroke.
Yes. So, and as Ravi was pointing out, the differential diagnosis between neuroleptic malignant syndrome, malignant hyperthermia, serotonin syndrome, and heat stroke. So, I think most of the differentials he told. So, the context, like background, clinical history, and all are important. So, any other things, sir, from your side? Ravi, do you want to add anything?
So just like we have, when you have a major trauma on the side, the ATLS guidelines say scoop and scoot, right? But in heat stroke, it is cool and transfer. Can't afford that 10 minutes or 15 minutes time uncooled. So if a patient is, for example, this software guy who collapsed on the road while running, and then an ambulance went to get him, uh, the first responder should understand that this is heat stroke, and should not be carried away that because it's happened in December, this cannot be heat stroke. Because this guy was running and he collapsed. So, and he had a cardiac arrest. So we don't know what happened with the cardiac arrest. It may be coronary syndrome, whatever. But according to Ravi, he had changed his diet. He was exercising regularly. So you can't expect coronary artery disease in this patient. So that arrest could possibly because of the hyperkalemia and metabolic acidosis of exertional heat stroke. So the person who is responding should be aware of this differential diagnosis and start cooling the patient while he's being retrieved in the ambulance to the hospital. Because the longer you take to cool the patient, the worse the neurological outcome. After 6 hours, you may put the patient on ECMO and cool the patient down to normal core temperature, and then hemodynamically he may stabilize, but they will be left with significant neurological sequelae if there is a delay in bringing the core temperature down. So that should be the most important learning point all of us should learn from this talk.
Yes, sir. That is important. I think more and more we had seen these type of cases recently. because more and more people are interested in marathon running and all. Sometimes they suddenly collapse, and you see the patients collapsing like that. Dr. Ravisankar, yeah, do you want to add anything?
Yes, sir. Like what sir has said, actually, this patient actually missed on the cooling part actually because he was retrieved with ambulance and we lost a good window by the time we reached the hospital. Then we realized that this patient had a heat stroke. Then we started cooling there. And fortunate that he did not land up in any complications, sir, other than abdomen.
Yeah.
Yeah, that's good. So I think the summary is, as we were discussing, the history and circumstantial exposure sometimes is important, and clinical examination gives a key. It remains a key. And background comorbid conditions and disease states, especially Ravi was pointing towards drugs usage, anti-Parkinsonian drugs, antipsychotics, anticholinergics also important. And as Sir was pointing out, high grade of suspicion is important, and you have to look at any typical presentations and take them into consideration while considering the possibility of this heat stroke. And as we were discussing, the rapid cooling is the key. And even if the hemodynamics are very unstable, maybe advanced treatment modalities like VA ECMO may play a role, definitely, along with other supportive measures and organ dysfunctions. So they have to tackle, and they may be having short-term and sometimes even long-term effects. I think with this, any final comments, sir?
I think it's quite relevant. I mean, points to learn is that heat stroke doesn't always happen in summer. To clearly know what is hyperthermia, what is hyperpyrexia, and always keep this in the differential diagnosis of somebody who presents to you with a temperature of more than 104 with hyperkalemia and one of the organ dysfunctions, cardiac, hepatic, renal, or CNS dysfunction. I think if we can convey that message, I think we would have achieved our goal for this webinar.
Yes, sir. Thank you, sir. Thank you very much, sir, for coming
Thank
on
you.
board and
Thank
sharing
you very
your
much.
valuable. Sir, thank you, Ravi.
There is one question on the chat box. What imaging of the brain should be done? Ravi, you want to take that question? What imaging of the brain should be done?
I think here imaging of the brain is to rule out only other causes, sir. I think CT would be ideal in a patient who has actually collapsed. Other than that, there is no role of imaging per se. But if you talk about neuroleptic malignant syndrome, as a part of the differential workup, when we look at the differential diagnosis to rule out other conditions, probably we'll do an imaging rather than for these conditions.
Yeah. Okay.
Okay, sir. Right. Thank you, sir. Thank you, Ravi.
Thank you. Have a good day. Bye bye.
Thank you, sir. Thank you, sir.